And then some people may say, well, actually, does it? So some of the delay, and certainly the last 2 to 3 years, has just been the authors being very careful that they don't ruin something that already works well, and that actually they focus on making the tool more user-friendly, more relevant, and where possible, fine-tuning items to be more relevant to clinical practice. And any change leads people to be concerned. And George Bernard Shaw said all evolution in thought and conduct must at first appear as heresy and misconduct. And I think that we need to overcome those anxieties, and by the end of this talk you should feel that this is a tool that you're already familiar with, because most of the framework is the same, many of the items are going to be the same, and I'm going to take you through the changes and explain why they're there. So at the end of this, I hope that your concerns about it being heresy and misconduct will be alleviated. So the unmanualised changes that I've just talked about over the last decade, what have they been? Well, we've been coding in a non-numerical capacity, certainly for the last decade, and the manual clearly says that we should be using a numerical form. Well, version 3 fixes that, and now the manual is saying what trainers have been saying for the last few years. Structured scenario planning and management, which was taken originally from the RSVP, that's the Risk of Sexual Violence Protocol, that never appeared in the early versions of the HCR 20, so there was no guidance in how to approach scenario planning and management. Now, they've embedded into the manual ways to approach this in this really important part of the risk assessment process. The next thing is emphasis shifting from coding to formulation and planning. And when I first trained people in version 2 of the HCR 20, most of the emphasis was on getting your coding right, when actually that was just the first part of a really important process that led you through formulation and planning. And so the manual now much more clearly emphasizes the formulation and planning process and gives it a proper importance and gives you some guidance in how to approach it. And then the final change was about relevance of items. Again, RSVP brought in this sense that the formulation process can occur at the coding stage. Once you've coded all your items, you should move on to a relevance process of saying, okay, I've identified 6 or 7 items here, but are they all actually relevant to the formulation of this patient? So it's a sort of pruning process that is taking out items that maybe don't have a causal connection to the risk, items that maybe you don't have therapeutic ability to change, and allows you to start focusing in on a much more reduced formulation that will allow it in a sort of reductionist terms. And that's something that I'm going to talk about a little bit later. So I often say to people, as experienced HCR 20 version 2 practitioners, what items would you change or develop for version 3? Obviously we can't do this task because we don't have such an interaction on a webinar, but things that people have often mentioned in the past is some people have doubted the relevance of having an age requirement for the violence, and other people have said that the presence of violence is too low a threshold to really distinguish between the different kinds of violence that you see. So they're just 2 examples that people have talked about. Another one relates to relationships and whether it's too narrow to just limit itself to intimate relationships, and whether we should be talking about non-intimate relationships as well, which is something that's covered in other tools such as the RSVP. So the main things that have changed in version 3 is that there's been a clarification and development of items to include sub-items and indicator lists. So sub-items is a way of subcategorizing your items to aid the sort of sense of that item. They're really broad spectrum. It allows you to make a little bit more sense of what you're trying to get out of that item. The indicator lists are really to try and skill up all users to the same level. I think for a lot of us, version 2, we already kind of applied our own sub-items and indicator lists, but for relatively new people using the tool, they may not have done so, or they may have used these things to different degrees. So the idea of an indicator list and sub-items is just to improve the clarity of your answer, the consistency of your answer, and actually try and bring everyone to the same skill level. They've removed some items, and there's been a merging of other items, and I'm going to show you a comparison of version 2 and version 3 shortly. And then finally, they've decided that PCLR will no longer have its own item requirement. You can still do one, but it will be subsumed within personality disorder, and you'll be invited to do that if you think that it is relevant. Why is that the case? Well, probably for some quite complicated political reasons, and also for some clinical reasons. The PCLR is quite a static tool. I think some people in the field of psychopathy assessment and management are starting to realize that a limitation of the PCLR is that it's an actuarial-based measure and it can't show change. And in the future, that there's currently being trialed a tool that will allow change to be reflected, because it uses a lot more sort of objectival descriptors of the problems. And it actually brings the whole PCLR concept closer towards its original Cleckley origins, rather than the more familiar and forensic-based hair options. Sorry, I'm just going to stop that. So, some items are split into subcategories. I'll show you that as we go through. Others have been narrowed down in focus, and there's an increased emphasis on antisocial behaviour throughout, and you're going to see that quite clearly. And the reason for this is a lot of the evidence just clearly shows that antisocial behaviour is a good predictor of future violence. So there's a lot more questions expanding the scope of that that previously weren't so obviously present in version 2. So what are the general changes to historical items? Well, the consideration is the whole life course, and that means actually right up to the point that you assess the patient. And it also includes if you then reassess the patient. So if you have a starting point, say in 1998, and the person has no substance issues problems, but then in 2002 they're starting to use cannabis on the ward, well, that would lead you to go back to the historical items and change the item to substance misuse or substance use, and add in the fact that they are now using cannabis. So it's not fixed at the time that you first do an assessment. You can go back to the H items and change them if the life course of the patient has changed. Also, it doesn't have to be a currently active item. So if someone used illicit drugs back in the 70s but hasn't used them for the last 30 years, it's still present. It may not be relevant, but you still code the item as present. Finally, you need to consider changes over time. So an item might be more relevant at different time courses rather than a sort of chronic presence over the life course of the patient. So what I've done in this slide is the blue items represent the new tool, version 3, and the red items represent the more familiar 10 items from version 2. But what you will see is the same structure, and you're going to see a lot of familiarity in the items. The first thing I'll bring your attention to is there's been a language change that occurs throughout version 3. The items aren't loaded with a negative connotation, so rather than relationship instability for item H3, they just talk about relationships, and rather than employment problems for H4, they talk about employment. And you'll see this attitude throughout the tool being used in the language that's expressed. So let's look at item by item. H1 now says violence instead of previous violence, but pretty much it's the same item, except they've expanded it to include a time frame. So the sub-categorization of violence now takes you through 3 domains of childhood, adolescence, and adulthood. The threshold and the definition of violence pretty much remains the same, and we're going to talk about each of these items in a moment. So H2 is now freed up. Instead of it being young age at first violence that's now wrapped up in H1, we've got an extra item, and they put in there other antisocial behaviour. So I'm going to talk in a moment about other antisocial behaviour and what that means when we do the item description. Item H3 is relationships, and that's now an expanded item. We'll talk about that in a moment, but it includes intimate and non-intimate relationships. Item H4 is employment, and it's very similar to employment problems. It's hardly changed. Substance use, again, very similar to substance use problems. Major mental disorder instead of major mental illness, that's a small change in language, but here they've applied some categories to help you divide up between major mental illness, sort of more pervasive developmental disorder or organic problems, and affective disorders. H7 is no longer psychopathy, but is now personality disorder, which frees us up another item later on. And within personality disorder, you can address all personality disorders, and then separately antisocial personality disorder or dissocial personality disorder. And then if you want to, or if you think it's indicated, you can do some psychopathy testing within that item. But we've lost the requirement to do H7 psychopathy, and since a lot of people actually didn't have the proper training to do that, it was often an item that was omitted in version 2. Under H8, traumatic experiences, change of language from early maladjustment, there was a recognition that H8 was too broad an item. You could be both a perpetrator or a victim to score in H8 under version 2, and version 3 has narrowed it down to you being the victim. We'll discuss that a little bit later. Now we've got a freed up item. Personality disorder appeared at H7 because we dropped psychopathy, and instead they put in violent attitudes. So I've underlined there H1, H2 and H9, they're all talking about antisocial behaviour, antisocial attitudes, and this is the real emphasis that's loading up on the actuarial items within version 3, which is H1 to H10. So you can see the emphasis on antisocialness, you can see how they fitted it in and what they've had to move about to achieve that. H10, treatment and supervision response, is pretty similar to the prior supervision failure, but again using a more positive language, and we'll talk about that in a moment. We're moving on now to clinical and risk management items. You're asked to determine the relevance of the rating and the re-evaluation window. So you may be looking at someone over a month, 3 months or 6 months, depending on the period of time that's gone between the last rating and current rating. You may choose to re-evaluate as planned, so specify a date, maybe 6 months in ahead, that's going to be just before your next CPA planning meeting. You may say that you would trigger a reassessment at point of transition from one secure level to another after notable changes of function, maybe a patient that's deteriorating or there's been some organic change, or after a violent episode. And it's amazing how people still forget to update the version, the HCR 20, after there's been a new violent episode. And sometimes I see patients several weeks after a violent episode that nobody has updated at all. They wait for the next update, and actually that's wrong, because that patient may need to be moved, the team need to be reconsidering risks, and everything's going to be out of date if it's not taking new information into account. So C items, pretty similar. Again, in blue version 3, in red version 2. C1 is insight, just changing the terminology from lack of insight. They subdivide that in a way that probably a lot of us did naturally anyway, but we'll look at that in a little in the future. C2, negative attitude, has been dropped for a more antisocial focus of violent ideation or intent. C3, active symptoms of major mental illness, is now symptoms of major mental disorder. C4, impulsivity has changed to instability. Actually, the original concept was instability, and I think a lot of people had started to narrow down their consideration of impulsivity. They thought it just related to impulsive behaviour, when actually it relates to emotional instability and also to cognitive instability. So it's a broader definition, and you'll see that in the way that the item is structured. C5 is pretty similar. It looks at supervision response and treatment response rather than just unresponsiveness to treatment. So it's a slightly broader definition. The R items, often the ones that in research you would see the poorest inter-rater reliability. They try to improve that by making the items clearer. Plans lack feasibility has been changed to look at professional services available for the patient and how much the patient accepts those. R2 is living situation, which incorporates these stabilizers but broadens it much more to look at the home situation and environmental factors. Personal support is pretty unchanged. Treatment response and supervision, again, very similar to the non-compliance item. And finally, stress or coping is a slight broadening of the definition of stress that we saw in R5, and we'll talk about that in a few slides' time. So how has this tool been produced? There was a meeting from some of the major players across the world in Manchester in 2008, and that led to some beta testing from the earliest versions by the Dutch, Swedish and Germans, who have been involved with version 2 pretty much from the outset. Been a couple of studies, there's not an awful lot of literature out there. I think we can conclude from the studies that there have been that the inter-rater reliability is pretty much the same. I don't think the authors are saying for 1 minute that it's necessarily improved in terms of predictive value, AUC scores, etc. It's pretty much about the same. It's whether this tool is giving clinicians more information to use, whether it's more user-friendly, whether it improves consistency and communication of risk. So, version 3 is intended to be a dynamic management-orientated assessment. As before, it can be used in all settings because it was never designed or based on one population's data. It's relevant for males or females. It should only really be used in people 18 years or older. And this is an interesting point. It can be used regardless of the presence of violence or mental illness. So it is a true screening tool. We shouldn't be adding our own screening dynamic in there, saying, well, I'm not going to risk assess this person because they don't have a history of violence or mental illness. It may well be that that's the case, but it could also be that you haven't applied enough structure to understand what the issues are. So the recommendation is that it can be used for anybody, and indeed the best practice principle advice from the Department of Health 2007 say that we should be doing this no matter what part of psychiatry we practice and what populations we look after. The time frame, well, H is up to present time, and that will mean up to present time each time you do the assessment, so things can change. C is a 1 to 6 month framework, depending how regularly you're repeating your assessment. And the R is a speculative look at the next 6 to 12 months. So how do we do this? Well, it's the same process as before. We gather relevant information, we determine the presence of risk factors, and then in a separate process, having determined all the presence of all the items, we go into a repeat, but this time looking at relevance. So those items that are present, we then determine whether they are relevant, and that's the first stage in the development of a formulation. We then look at the items that we have determined are present and relevant, and we use a reductionist principle, something I'm going to talk about a little bit later, that allows us to come to the most simple explanation of why this person is at risk of this violence. We then develop our primary scenarios and our case management plans and our final opinion. Very similar actually to the process that we were doing for version 2. Quick mention of the consensus model. So what we're talking about here is not having one individual being responsible for producing the scoring of all the items. I think it's important that we use at minimum our team. It's fine to have someone have a lead in the tool. Sometimes that's the psychologist, sometimes the psychiatrist, and that lead person ensures that the information that is available is gathered, that the initial scorings are made, but that tool should then be discussed in a multidisciplinary forum that allows each person to contribute any additional information that might have been missed, or to discuss any items that are debated. And the way that you choose your final coding is a consensus view based on the people's views at that meeting. So if you've got 4 people present and 3 people think something is present, then you're going to say it is. Obviously, if you have 4 and only 2 people say it is, 2 people don't, you need to have further discussion. I think it's really important to try and start to believe that you can bring a patient into this process. A patient's never going to dominate a consensus view, but I think they should be able to contribute their view. How are they going to do that? You're probably going to start to educate the patient about risk assessment first, prepare them so they can be a useful participator. But my view probably in the future is these risk assessment tools will be seen as at their most useful when patients become better determiners and decision makers of their own risk, rather than us doing it in a parental fashion for them. Because when they leave the doors of their hospital, ultimately it's only what they've internalized in their own head that's going to allow them to think about risk and avoid situations before they arise. But that's another talk. Let me just remind you about the structured clinical judgment process. It's a dynamic process. You consider the relevant factors. That involves considerations of risk. HCR 20 version 3 chose not to look at protective factors. You could argue that they should have looked at integrating the work by our Dutch colleagues on SAPROS, but they've chosen not to, and at this stage we're left to either clinical judgment or the use of a tool like SAPROS to balance out the fact that we've predominantly looked just at risk factors of our patients. When we think about risk management, we have treatment, monitoring, supervision, and victim safety planning. These are the domains that we need to consider. We need to remember that this is a dynamic feedback process. And it's a cyclical process. We collect information, we evaluate its presence, we evaluate individual relevance, we scenario plan and formulate, and then we develop a risk management strategy. And then as we go through our cycles of risk, we update our information, we reevaluate presence, we reevaluate relevance, we update formulation, and we update our risk management plan. And this process doesn't stop throughout the patient's care. We need to think about context, particularly for the R items. Is this patient going to be static, i.e. remaining where they are, or are they in a period of transition? If they're in a period of definite transition, we need to think about what they would be like in a different situation. And if they're in a possible transition, we need to possibly cover both options and consider them remaining on the ward or moving to a different setting or even into the community. This ratings will be familiar to you. We don't code with numbers anymore because that leads to errors of judgment, people believing that a score of 2 for one item is the same as a score of 2 for another, when actually it's the formulation and how you understand the risk that is important. So the no, possible, yes remains the same. They've added in a myth because people were making some errors in their coding and saying that a no for when they didn't have sufficient information or even a partial. Omit is the one to choose if you don't think you have reliable information to make a judgment. Relevance is now defined in the manual. I'll try and give you a definition that helps. You need to say to yourself whether this item that is present is either functionally related, influences decision making in the individual, impairs the individual's capacity, or maybe even mitigates risk. It could be relevant because it actually has a protective role. And if these things, if one of these things or more are present, then it is likely to be relevant in your formulation of why this person becomes violent and how you're going to intervene with your therapeutic options. And when we formulate, we need to think of predisposing factors, that's risk factors identified from the tool risk assessment. Precipitating factors, those triggers that are identified from our scenario planning exercise. Perpetuating factors, what factors maintain the risk over time, and any protective factors that we need to take into consideration. And sometimes people view the precipitating factors as your destabilizers and your protective factors as your drivers for reducing risk. So what is formulation? At its simplest definition, it is simplification through revision. What is the simplest aggregation of risk factors that explains why this person commits violence? This is just an example. Imagine you do an HCR 20 and it identifies 6 items that are present, but you determine in your explanation, the simplest explanation of why this person commits violence, that actually only 3 items are relevant. It's this person's underlying antisocial personality, their use of illicit drugs, and then their eventual destabilization into a psychotic state that explains why and when they become violent. And actually their history of childhood trauma, their problems with insight, and their impulsivity are not factors that you think are directly relevant to why they become violent. Or you may have a formulation that includes all 6, but the main point is that you're trying to simplify and come to the most basic model of explaining the violence. Scenarios can be repeat scenarios, someone doing the same thing that they've done before. They can be escalation scenarios, something's going to get worse but along similar lines. It could be a scenario with a twist, something that you haven't quite predicted coming, but maybe there's some indicators in there that it could repeat in a slightly different way. Maybe a violent crime becomes a sexual crime. And then of course we need to consider in the back of our minds that actually what the goal of all of our work is that we have an improvement scenario that the patient doesn't become violent. Management strategies, we have monitoring, treatment, supervision and victim safety planning. And I'm going to move on now to item descriptions and give you a little bit more detail about each item. Basic principles for historical is it can be at any point in a person's life. It does not need to be currently active, and you need to consider course and changes over time. So H1 violence, the definition remains the same, but it can be physical or psychological violence. And that means that it can include stalking, arson, kidnapping, and most sexual offences. If it was a sexual offence, you would want to complete an RSVP as well as an HCR 20 because it's going to allow you to go into far more detail about the psychological triggers and descriptors of the violent offending. A clear pattern means 3 or more distinct occasions, but you can also have one single event of violence that is serious and would lead you to consider it as relevant. You need to consider these 3 subcategories when the child is less than 12, between 13 and 17, and when they are an adult. And so you can see that items H1 and H2 of the earlier version have been combined into one item. Other antisocial behaviour. This is looking at a history of problems stemming from the person's perpetration of antisocial behaviour other than violence. You can look at all the developmental stages, childhood, adolescent, adulthood. And you need to look at behaviour that needs deliberation and willfulness without lawful authority. And a clear pattern again would be 3 or more occasions. So your patient that's not being violent on the wall, but is being social, maybe they're bullying, breaking rules, being verbally aggressive, you can now start to take this into consideration when you're considering their future risk of violence. Relationships looks at both problems in establishing or maintaining relationships, and now you can consider intimate and non-intimate relationships. The focus is on community and not institutional. I think the reason for this is because the evidence is more focused on, is more based on community relationships than it is on institutional. And so the authors have chosen to focus in on that. Employment really hasn't changed. Any history of serious problems seeking, maintaining or abiding by the rules of legal employment. Institutional employment does count. You need to take the age and the economic opportunity into account. We're just coming through a recession, a lot of people are unemployed, not through choice. And you can count education within employment. Substance use hasn't really changed. It's a history of problems with the use of, abuse of, or dependence on mind or mood-altering drugs. It would include alcohol, illicit drugs, prescribed drugs, or incidental substances. It can include casual or infrequent use with no associated problems to mind or mood should be coded. I know this was a big issue before. What do you do with someone that's had some cannabis use but you've not actually been able to evidence that there's an associated problem to it? Do you code it as a possible because that's some use, or do you code it as a no? The authors are clear now. If they've had casual or infrequent use with no clear associated problems in mind, mood, or behaviour, then you can code it as a no. Impairment of function is focused on mental health, physical health, employment, and relationships, and you can consider steroids under this item. Major mental disorder. They've looked at disorders of cognition and affect, serious interfering with a person's important domains of functioning. Subcategories are now in place. I used to use these anyway, but I think it's helpful to think about it. The person can have a problem with psychotic disorders, major mood disorders, or disorders primarily affecting intellect, executive functioning, social and interpersonal functioning, i.e. the pervasive developmental disorders like autism. What the authors advise is that you stick to the category that explains the violence. So that item which you think is most relevant is the one that you code, even if they may have items that are counted under multiple domains. Personality disorder. This is a history of serious problems resulting from fixed maladaptive personality traits. You're looking for chronicity and pervasiveness. You can consider antisocial personality disorder separately to the others because you're considering it under a number of items in the H domains. And if you assess psychopathy, you still need to use a recognized tool, which currently is the PCLR or PCLSB. I discussed traumatic experiences earlier. This is any point in a person's lifespan that may disrupt normative development, but they've taken out the perpetrator role. Being a bully as a child, being a sex offender as a child is no longer relevant to this item. It's about being a victim or experiencing a traumatic situation. It can also relate to poor parenting and caregiving. Violent attitudes. This is a history of entrenched violent attitudes, beliefs, values, or thoughts, such as the belief that violent behaviour is justified to meet personal goals, any beliefs that support or condone violence. And you can infer it from a repeated pattern of behaviour, not necessarily from admissions by the patient. Sadism is relevant here. Treatment or supervision response. So here we have serious problems complying with or responding to forensic mental health or correctional treatment, rehabilitation, or supervision targeting reduction of violence. You can include a poor motivation of the patient, unwillingness or refusal to attend treatment, or to conform to supervision framework. Clinical items. So 3 subsections: mental disorder, violence risk, or need for treatment when considering insight. I think, sorry to jump around, I think this was always the case. It's just that some people didn't always consider insight to be under these 3 domains, but now they've just made it a little bit clearer. They've asked you to consider each one in turn. Violent ideation. This is a narrower definition than just negative attitudes. It relates to current serious problems related to violent ideation or intent. It includes thoughts, plans, desires, fantasies, and urges to cause harm to others. You don't want to code it if it occurs solely in the context of psychosis. And serious would mean intent or ideation that's persistent and intrusive. Once more, you can infer it just from the patient's behaviour, not necessarily from their admissions. Symptoms of major mental disorder, 3 subgroups: psychotic disorders, people with hallucinations, delusions, irritability, agitation, aggressiveness; major mood disorders, covering mania, hypomania, depression; and then disorders that primarily affect intellect, executive functioning, or social and interpersonal functioning. And this last item may change very little over time. I've talked about instability. I'll just describe it a little bit more. Current serious problems maintaining stable adjustment with respect to affect, behaviour, and cognitive functioning. Treatment supervision response. This is current problems accessing, attending, being compliant with, or benefiting from mental health, forensic, or correctional interventions designed to reduce risk of violence. 2 subgroups: the compliance, this is problems with attending or participating, and responsiveness, which is problems from actually benefiting from your intervention. Risk management scale, professional services. This reflects future problems related to developing general plans that make appropriate use of professional services. They may be deemed to be inadequate when they've not been communicated well to others, they're unclear or lack detail. Maybe they fail to take into account recommendations of evaluation, such as additional independent reports or forensic evaluations. And sometimes a lack of appropriate services may merit a yes. So unmet needs can be identified in this item. Living situation. It is future problems with an evaluee's living situation. Key consideration is whether there are features of such domains that could destabilize the patient. You can look at housing, weapons, substances, deviant peer group, specific victim groups, etc. Personal support hasn't really changed, except they make clear now that you exclude professionals. So if a chronic schizophrenic patient's only support network is the professionals he engages with, that does not merit a yes within this item. You need to think about family, friends, neighbours, co-workers, and acquaintances. Treatment or supervision response. It is future problems in accessing, attending, being compliant with, or benefiting from any treatment strategies for reducing the risk of violence. So you would code failure of patients to accept future treatment plan on discharge. Again, you subcategorize it into compliance and responsiveness. Stress or coping. This is a person's ability to cope with stressful circumstances and life events. You need to consider this on an external and an internal plane, external being major life events, and internal looking at inadequate coping strategies to that stress. R2 can be coded here if the person finds exposure to them stressful. Thank you, and questions. I think we have a small period of time to take any